Welcome to the deep dive. You're here to nail acute pancreatitis for your MSRA, right? Think of this as your turbocharged revision session, really zeroing in on exactly what you need to know to master this key condition.
Absolutely. Acute pancreatitis is, well, it's definitely a must-know for the MSRA. It's essentially a sudden inflammation of the pancreas, causes pretty significant abdominal pain, and it can affect the whole system too.
Right.
And what's really important to grasp, I think, is that it's not all or nothing. It really ranges from, relatively mild episodes to very severe, potentially life-threatening situations.
Okay. So to get us started then, let's really pin down what we mean by acute pancreatitis. What's the sort of essential definition you should have in your head?
Sure. So at its core, acute pancreatitis is a sudden inflammatory process right there in the pancreas. This inflammation leads to the release of the pancreas's own digestive enzymes, the exocrine ones, and these enzymes actually start to digest the pancreas itself. Yeah, we call that autodigestion. And this process, it isn't just limited to the pancreas. It can spread to nearby tissues, even affect organs further away. So for your MSRA, I'd say remember the key elements: sudden onset, inflammation, that characteristic abdominal pain, potential systemic effects, and definitely that self-digestion piece.
Makes sense. Autodigestion. Got it. So what are the common triggers? What kicks off this sudden inflammation? What are the usual suspects we should be thinking about?
Well, the top two by far are gallstones and excessive alcohol consumption, easily the most common. So if you see an MSRA question describing a patient, severe abdominal pain, history of either of those, acute pancreatitis should be really high on your list.
Okay.
But there are other causes too, and actually a really helpful way to recall them all is with the mnemonic "get smashed." It's a classic for remembering the etiology.
Get smashed. Okay, I like it. Sounds memorable. Let's break that down then. What does each letter stand for?
Okay, let's do it. G is for gallstones. Pretty straightforward. Think of a stone blocking the bile duct, which can then back things up and obstruct the pancreatic duct.
Right.
G is for ethanol, so excessive alcohol intake. The exact mechanism for alcohol-induced pancreatitis isn't perfectly understood, but it's definitely a major factor.
Okay.
D is for trauma. This could be direct, blunt trauma to the abdomen, but also really important to remember post-ERCP pancreatitis.
Yeah.
That procedure carries a known risk.
Yes, ERCP.
Good point. Then S covers steroids. Certain steroid medications are associated with it. The next M is for mumps, though other viruses like Coxsackie B and hepatitis can also potentially trigger it.
Mumps, interesting.
A stands for autoimmune diseases like polyarteritis nodosa and also some less common infections like Ascaris worms.
Right.
Then we have another S for scorpion venom, thankfully not one you'll likely see much in the UK.
Phew.
AGIC is, well, age is a bit of a collection. Hypertriglyceridemia, hyperchylomicronemia, hypercalcaemia, hypothermia, hyperparathyroidism, uremia, and even anorexia.
Wow, quite a list under H.
Yeah, notice how many of those H causes involve metabolic disturbances? It kind of highlights the systemic impact pancreatitis can have.
That's a good point. It really links it to other systems.
All right.
What are the last couple and get smashed?
Right, so the next E is for ERCP itself. As we already mentioned, the procedure can cause it.
Okay.
And finally, D is for drugs. And there's actually a surprisingly long list of medications linked to acute pancreatitis. Things like azathioprine, mesalazine, didanosine, bendraflumethiazide, furosemide, pentamidine, steroids again, sodium valproate, thiazides, L-asparaginase, corticosteroids, a few others too.
So always worth checking the medication history then.
Definitely. Always worth a look.
Get smashed, that's pretty comprehensive. Are there any less frequent causes, things that might pop up in an MSRA question to try and catch us out?
Yeah, there are a few less common ones just to keep in the back of your mind. Think about malignancy, especially tumors around the ampulla of Vater or pancreatic cancer itself. Ischemia could do it, perhaps due to a blood clot affecting the blood supply to the pancreas. There's also a noted association with inflammatory bowel disease, particularly linked to mesalazine use in some people.
Right, IBD.
And then you've got some real rarities like alpha-1 antitrypsin deficiency, certain structural abnormalities of the pancreas, vasculitis, things like that. So yeah, while Get Smashed covers the really high-yield stuff, being aware of these less common ones might just help you in those trickier scenarios.
Good to know. So we know what the causes. What about the who? Are there specific factors that make someone more prone to getting acute pancreatitis? What are the key risk factors we should know?
Yeah, the risk factors largely mirror those common causes we just went through. So having a history of gallstones or heavy alcohol use are major risk factors. That's number one and two.
Right.
Obesity and smoking also increase the likelihood. Interestingly, there can sometimes be a genetic predisposition, so a family history of pancreatitis is something to note. And like we just discussed with the D and get smashed, certain medications will definitely put individuals at higher risk. So you need to think about lifestyle, past medical history, family history, and current medication use when assessing risk.
Be clear. We know what can start it
Yeah.
and who's more at risk. Now let's dig into what's actually happening inside the body. What's the core pathophysiology? What's going wrong?
Right. So the central problem, the absolute core of it, is the premature activation of those really powerful digestive enzymes within the pancreas itself.
Okay.
Instead of being safely activated down in the small intestine to digest food, they become active while they're still inside the pancreatic tissue. And this leads to that autodigestion we mentioned. The pancreas essentially starts, well, digesting its own cells. It causes significant tissue damage.
Oh.
And this premature activation can be triggered by various things like a blockage in the pancreatic duct, often by a gallstone, or maybe direct injury to the pancreatic cells from alcohol, or even systemic inflammatory responses setting it off. And the result is inflammation, swelling, we call that edema, and eventually cell death, or necrosis. This obviously impairs the normal function of the pancreas, but also leads to those systemic effects we talked about earlier. Understanding that initial enzyme activation and the resulting cellular damage is really key to understanding why patients get so sick.
That internal self-destruction, yeah, it sounds pretty dramatic.
Mm.
So when someone presents with these kinds of severe abdominal symptoms, what other conditions might be causing them? What should be on our differential diagnosis list for acute pancreatitis?
That's a critical area for the MSRA, definitely. You absolutely need to be able to distinguish acute pancreatitis from other potential abdominal emergencies. Chronic pancreatitis is an important one. Remember, that's the long-term inflammatory condition, whereas acute is sudden onset. Big difference in presentation and management.
Right.
You should also consider things like a gastrointestinal perforation, a hole somewhere in the gut. Cholecystitis, which is inflammation of the gallbladder. And remember, gallstones cause pancreatitis, so they can coexist or mimic each other.
Good.
Also think about gastritis and peptic ulcer disease. The location and character of the pain can sometimes overlap quite a bit.
Okay. And what about those raised amylase or lipase levels? We rely on those a lot for diagnosis, right?
Mhm.
But are there other reasons they might be elevated, potentially misleading us?
Absolutely, great question. While elevated amylase and especially lipase are key indicators, they're not, 100% exclusive to pancreatitis.
Ah.
For example, renal failure can reduce the clearance of these enzymes from the blood, leading to raised levels even without pancreatitis. Other things like ectopic pregnancy, diabetic ketoacidosis, DKA, a perforated duodenal ulcer, even mesenteric ischemia or infarction can also cause elevated amylase.
Okay.
Lipase tends to be a bit more specific for pancreatic issues. It hangs around longer too, but still, you always have to interpret lab results in the context of the whole clinical picture, not just the numbers.
Good point. So it's not just about the lab slip. What other conditions might present with similar severe abdominal pain, even if the amylase or lipase isn't sky high or maybe hasn't been checked yet?
Yes, exactly. The abdominal pain in acute pancreatitis can really mimic several other serious conditions. You definitely want to consider things like a small bowel perforation or maybe an obstruction. A ruptured or dissecting aortic aneurysm is a big one, especially in older patients with vascular risk factors. That's a can't-miss diagnosis.
Absolutely.
And even sometimes atypical presentations of a myocardial infarction, a heart attack, where the pain might be felt primarily in the upper abdomen rather than the chest. So a thorough history and examination are absolutely crucial to try and differentiate these.
Okay, right. Let's shift gears slightly then and talk about how common this condition actually is.
Yeah.
What does the epidemiology of acute pancreatitis tell us, particularly in the UK context? That's what's relevant for the MSRA.
Yeah, good question. In the UK, acute pancreatitis is actually quite common. And interestingly, the number of cases seems to have been increasing over recent decades.
Really?
Increasing? Yes, data suggests that. There are also some notable gender differences. Gallstone-related pancreatitis tends to be a bit more frequent in women, while alcohol-related pancreatitis is, perhaps unsurprisingly, more commonly seen in men.
Right.
There was UK data specifically looking between 1990 and 2013 that showed quite a significant rise in incidence in both sexes over that period. And hospital data specifically from Wales indicated an average annual increase, with an overall incidence around maybe 30 cases per 100,000 people per year.
30 per 100,000. Okay.
Globally, the estimated incidence is often quoted in a similar range, but it's worth knowing there are geographic variations. The UK and the Netherlands tend to report slightly lower rates compared to places like Scandinavia and the USA. But for your MSRA, I think the key takeaway is understanding that it's a common condition in the UK and potentially becoming even more common.
That's really useful context. Thanks. Now let's move on to what it actually looks like when a patient presents. What are the typical clinical features we should be alert for? The signs and symptoms.
Okay, the classic presentation, the one you'll read about, is severe sudden onset pain, usually in the upper middle part of the abdomen, the epigastric region, and crucially, it often radiates straight through to the back, like a boring pain.
Radiating to the back. Okay.
This pain is frequently accompanied by nausea and pretty significant vomiting. On examination, the abdomen will typically be tender, sometimes exquisitely so. You might also observe things like a mild fever, maybe some evidence of hyperlipidaemia if you look closely, probably an increased heart rate, so tachycardia, potential jaundice if a gallstone is involved.
And are there any specific characteristics of the pain itself that might offer more clues?
Yes, patients often describe the pain as being most intense, maybe in the left upper quadrant, although sometimes it feels like a tight band sort of encircling the upper abdomen. The pain usually builds up quite rapidly and then tends to gradually decrease in intensity over about 72 hours, assuming, there aren't any complications developing.
72 hours.
Okay. If the pain persists or actually gets worse after that sort of time frame, it should definitely raise your suspicion for complications.
Right. And what about those specific sort of maimed physical signs we sometimes learn about, like Cullen's sign and Gray-Turner's sign? When might we actually see those? Are they common?
They're not common, but they're important signs of more severe disease. They indicate retroperitoneal hemorrhage, bleeding behind the abdominal lining.
Okay, bleeding.
Yeah. Cullen's sign is bruising around the umbilicus, the belly button, and Gray-Turner's sign is bruising on the flanks, the sides of the abdomen, sort of towards the back. Seeing these is definitely a red flag for significant bleeding associated with the pancreatitis. It implies a much more severe process.
Got it. Red flags.
Other signs of severe pancreatitis can include things like low blood pressure, hypotension, maybe a higher fever, rapid breathing, tachypnea, fluid accumulating in the abdomen that's ascites or around the lungs, pleural effusions, and low blood oxygen levels, hypoxemia, and always correlate these findings with the patient's history. For instance, someone with known heavy alcohol use or known gallstones presenting with this kind of severe pain profile, it strongly suggests those as the underlying cause.
Okay, so a patient presents, they've got these concerning symptoms, maybe some worrying signs. What's our next step? How do we investigate? What initial tests are crucial?
Right. The initial workup always involves blood tests first. We'll definitely be looking at serum amylase and, importantly, serum lipase levels.
Amylase and lipase.
Yeah. Lipase is generally considered more specific for pancreatic inflammation, and it tends to stay elevated for longer than amylase, which can be helpful. We'll also order a full blood count looking for signs of infection or inflammation, like a raised white cell count. Liver function tests are essential too, to assess for any biliary involvement, like a blockage causing raised bilirubin.
Okay, blood's first.
Oh.
What about imaging?
Abdominal imaging is also essential, yes. An ultrasound of the abdomen is often the first-line imaging test. It's particularly useful for detecting gallstones in the gallbladder or seeing if the common bile duct is dilated, and sometimes it can show swelling of the pancreas itself. It's quick and non-invasive.
Ultrasound for stones mostly then.
Primarily, yes, and bile duct assessment. However, a contrast-enhanced CT scan of the abdomen is really the gold standard. It's better for both confirming the diagnosis of acute pancreatitis and, crucially, for assessing its severity and identifying any potential complications like necrosis or fluid collections.
CT for severity.
Right. MRI might have a role in specific situations, perhaps to get a better look at fluid collections or biliary ducts, or maybe in patients where CT contrast is contraindicated, like severe renal impairment or allergy.
Okay. Now, I know there are various scoring systems and classifications we use to try and predict how severe a case might be and help guide management. Can you give us a quick rundown of the important ones for the MSRA?
Absolutely. You're right. Several prognostic scoring systems help us assess severity early on. The Glasgow Prognostic Score, sometimes called the Modified Glasgow Score, Ranson's criteria, and the APASI-2 score are among the sort of established ones you might hear about.
Glasgow, Ranson's, Apache 2.
Yeah. We also monitor inflammatory markers, particularly C-reactive protein levels, CRP. A rising CRP often indicates worsening inflammation and potentially more severe disease. But the main classification system you need to know is the Atlanta classification. It's the widely accepted system now. It categorizes acute pancreatitis into mild, moderately severe, and severe.
Mild, moderate to severe. Okay.
And that's based primarily on the presence or absence of local complications, like necrosis or pseudocysts, and systemic complications, specifically organ failure, respiratory, cardiovascular, or renal failure, and whether that failure is transient or persistent.
Based on complications and organ failure. Makes sense.
Exactly. So for your MSRA, understand that these systems exist to help stratify risk and guide the intensity of management. You might also sometimes encounter simpler scores like BIASAP, but honestly, the Atlanta classification is the key one to be familiar with for defining severity.
Okay, Atlanta classification. Got it. So we've made the diagnosis, we've assessed the severity. What's the mainstay of treatment? How do we actually manage these patients?
Right. The absolute cornerstone of management is supportive care. That's number one. This includes really effective pain relief, and that usually requires intravenous analgesia, often opiates initially.
Okay, pain relief.
Then aggressive intravenous fluid resuscitation. This is crucial to maintain adequate hydration and organ perfusion. We often target a specific urine output, maybe a 0.5 to 1 milliliter per kilogram per hour as a guide.
Fluids.
Exactly. If the patient is experiencing really severe nausea and vomiting, a nasogastric tube might be considered for gastric decompression, just to make them more comfortable. Early and continuous hydration, usually with crystalloid solutions like Hartmann's or saline, is vital in those first 24-48 hours.
Okay. And what about nutrition? I seem to recall the traditional approach was always to keep patients nil by mouth for quite a while. Has that thinking changed?
Yes, absolutely. The approach to nutrition has evolved significantly based on better evidence. We now generally avoid prolonged periods of nil by mouth in most cases.
Oh, really?
Yeah. For patients with moderate to severe pancreatitis who can tolerate it, early enteral nutrition, so feeding via a tube like a nasogastric or ideally a nasojunal tube placed beyond the stomach, is actually preferred.
Enteral feeding, how early?
Ideally, starting within 72 hours, maybe even 48 hours if possible. This is preferred over complete starvation or giving parenteral nutrition, which is intravenous feeding. Parenteral nutrition, or TPN, is typically reserved now for situations where enteral feeding just isn't feasible or isn't tolerated for some reason.
That's quite a big shift in thinking then. What's the rationale behind moving towards early enteral feeding? Why is it better?
Well, quite a bit of evidence has shown that early enteral nutrition is associated with better outcomes overall. We see a reduction in mortality, lower rates of organ failure, fewer infections, both pancreatic and systemic, a decreased need for surgical or other interventions later on, and even shorter hospital stays.
Wow, quite a few benefits.
Yeah. It seems to help maintain the integrity of the gut barrier, modulate the inflammatory response, and prevent bacterial translocation. Basically, keeping the gut working seems to be beneficial.
It makes a lot of sense. And what about dealing with the underlying cause? We can't forget that.
Absolutely not. Identifying and treating the underlying cause is obviously critical, both for the acute episode and for preventing recurrence down the line. So for gallstone-related pancreatitis, which is very common, an early cholecystectomy removal of the gallbladder is often recommended, usually done during the same hospital admission once the acute inflammation has settled down a bit.
Okay, get the gallbladder out.
Yeah. If there's clear evidence of a stone actually lodged in the common bile duct causing obstruction, or if the patient has cholangitis, then an early ERCP might be needed within maybe 24-72 hours to remove that stone first, followed by cholecystectomy later.
Right, ERCP for obstruction.
And obviously, if the pancreatitis is due to alcohol, then clear advice on alcohol cessation and offering support for that is absolutely essential. For the rarer causes, management will be tailored to that specific underlying condition.
Okay. And what about more invasive treatments like surgery? You mentioned ERCP, but when do we actually consider operating on the pancreas itself?
Good question. Surgical interventions are generally reserved for cases with specific complications, most commonly infected pancreatic necrosis or perhaps persistent organ failure despite maximal supportive care.
Infected necrosis, okay.
If that dead pancreatic tissue, necrosis, gets infected, which significantly worsens the prognosis, it usually requires debridement, the removal of the dead infected tissue. Now, how that's done has evolved. Increasingly, endoscopic approaches, going via the stomach or duodenum, or radiological approaches with percutaneous drains, are used first. These are often called step-up approaches.
Less invasive first.
Exactly.
Yeah.
Minimally invasive is preferred. Open surgical necrosectomy is generally reserved for cases where those methods aren't feasible or fail. The timing is also crucial. There's often a balance between intervening promptly to control infection and delaying intervention to allow the necrotic area to become better demarcated or walled off, which can make debridement safer. Usually, intervention is delayed for at least 4 weeks if possible, unless the patient is rapidly deteriorating due to sepsis.
Right, timing is key. We've covered diagnosis, management. What's the outlook for patients who develop acute pancreatitis? What does the prognosis generally look like? Is it always bad?
No, not always bad. The prognosis really varies significantly depending on the severity of the attack. The good news is the majority of mild cases, maybe around 80%, will resolve without any major complications, and patients generally have a good long-term outcome.
80% mild resolve well. That's good.
Yeah. However, some individuals may unfortunately experience recurrent episodes, especially if the underlying cause isn't addressed, like ongoing alcohol use or retained gallstones. And there's always a small risk of developing chronic pancreatitis as a longer-term consequence, particularly after severe or recurrent episodes.
And the mortality?
Well, the mortality rate in mild acute pancreatitis is relatively low, typically quoted as less than 5%. But in severe cases, particularly those with infected necrosis or persistent organ failure, the mortality rate can be significantly higher, sometimes reaching up to 30%. It's a serious condition when severe.
30% in severe cases. Wow.
And even for survivors of severe pancreatitis, there can be ongoing issues. Some patients might develop pancreatic exocrine insufficiency, meaning they don't produce enough digestive enzymes, and might need enzyme replacement therapy, sometimes for up to 2 years or even longer. Glucose intolerance is also quite common after pancreatitis, although developing permanent diabetes is less frequent, but it can happen.
So long-term follow-up is important then. Are there any preventative measures people can take to reduce their risk in the first place?
Absolutely. Prevention is key where possible. Avoiding excessive alcohol consumption is probably the single most important modifiable risk factor for preventing alcohol-induced pancreatitis.
Hey, stop the booze.
Pretty much. For individuals who are found to have gallstones, especially if they've had symptoms, considering an elective cholecystectomy can effectively prevent future episodes of gallstone pancreatitis. And in those rare cases of very, very high triglyceride levels, severe hypertriglyceridemia-specific treatments like fibrates or even plasmapheresis might be considered to lower those lipid levels rapidly and reduce the risk.
Okay. Finally, let's just make sure we cover the potential complications properly. It sounds like acute pancreatitis can have pretty far-reaching effects beyond just the pancreas itself.
It certainly can. The complications can be broadly divided into local complications, those affecting the pancreas and the immediate surrounding area, and systemic complications, affecting other organ systems throughout the body.
Okay, let's start with local ones.
Sure. Local complications include pancreatic necrosis, which we've touched on. That's dead pancreatic tissue. Diagnosis is usually by contrast-enhanced CT, and rising CRP might suggest it. The big worry is infection of the necrosis, which happens in about a third of cases and dramatically increases mortality. Management involves antibiotics if infection is suspected or proven, and often debridement.
Necrosis, got it. What else?
Acute fluid collections are common, especially early on in severe pancreatitis. They're basically collections of inflammatory fluid around the pancreas. Many resolve spontaneously. A pancreatic abscess is different. That's a collection of actual pus. It typically develops later, maybe several weeks into the illness, and almost always requires drainage, either percutaneously or surgically.
Abscess needs draining.
Okay. Then you have acute pseudocysts. These are collections of pancreatic juice enclosed by a fibrous wall. They usually form after about 4 weeks. They can cause pain, get infected, rupture, or bleed. If symptomatic or large, they often need drainage, sometimes endoscopically or surgically.
Pseudocysts, different from abscesses then.
Yes, different contents and timing. Pancreatic ascites can occur if a pseudocyst ruptures into the abdominal cavity or if there's a leak directly from the pancreatic duct. Treatment might involve IV feeding to rest the pancreas, drugs like somatostatin analogs, or sometimes surgery. And finally, sometimes acute cholecystitis, gallbladder inflammation can develop as a secondary complication, particularly in severe cases.
Okay, that covers the local problems. What about the systemic complications? Those sound like they can be particularly serious contributors to the overall illness.
Yes, the systemic complications are often what lands patients in intensive care and contribute significantly to morbidity and mortality. Respiratory complications are really common. You can get pulmonary edema, pleural effusions, fluid around the lungs, lung collapse or consolidation, and in severe cases, ARDS, acute respiratory distress syndrome, which is life-threatening lung injury.
ARDS.
Varus.
Very.
Cardiovascular complications can include significant hypovolemia from fluid shifts, potentially leading to shock and organ hypoperfusion. There's also a risk of developing DIC-disseminated intravascular coagulopathy, which is a serious disorder where the clotting system goes haywire.
DIC. Okay.
Renal dysfunction or acute kidney injury is also common, often due to that hypovolemia and poor kidney perfusion, sometimes complicated by coagulation issues. Preventing it with aggressive fluids is key. Low-dose dopamine used to be mentioned, but isn't standard practice now.
Fluids again.
Always fluids. We can also see metabolic disturbances, low calcium, hypocalcemia, low magnesium, hypomagnesemia, and often high blood sugar, hyperglycemia due to the stress response, and pancreatic islet cell dysfunction. Rarely, permanent diabetes can result. Gastrointestinal complications beyond the pancreas itself can include things like upper GI hemorrhage, maybe from stress ulcers, or ileus, a temporary paralysis of the bowel. And then there are some rarer systemic things like Weber-Christian disease, which is subcutaneous fat necrosis appearing as painful skin nodules, and splenic vein thrombosis, which can lead to gastric varices later on.
Wow. So quite a list of potential problems, both local and systemic. It really underscores the severity. Okay, so to summarize then, acute pancreatitis is clearly a serious condition. It's got a wide array of potential causes, with gallstones and alcohol being the big ones you need to remember for MSRA. Prompt diagnosis, recognizing the severity early, using tools like clinical assessment and maybe the Atlanta criteria, and then initiating comprehensive supportive management fluids, pain relief, nutrition are absolutely vital. And of course, addressing the underlying cause to prevent it happening again.
Exactly. That's a great summary. And perhaps just thinking about how lifestyle factors, particularly alcohol, but also things like obesity, can contribute to the development of acute pancreatitis.
Yeah.
Well, it's definitely something worth reflecting on, both for the exam and, for future clinical practice when advising patients.
Absolutely. A really important point to consider. Well, that brings our comprehensive deep dive into acute pancreatitis to a close. Hopefully that's given you a solid foundation for your MSRA revision. For even more high-yield resources to help you ace your MSRA exam, be sure to check out pastmsra.com and also our free resources at freemsra.com. Thanks so much for joining us on this deep dive, and until next time, keep revising smart.